Live from Chicago at ASCO, we're here with Professor Teshpar from Leuven. Professor Teshpar, thank you for being with us. Could you put in perspective the results of the CLBG study that was presented here, the data from the Crystal study, from the Fire 3 study, with the knowledge about the RAS pathway?
First comment is that this knowledge indeed on the RAS pathway evolves very quickly. And I think that's an important comment because the trial designs, and the time it takes to run a trial versus this evolving knowledge are not well synchronized. So I think certainly what we saw for the CLGB is that the intention population of KRAS wild type was presented, and this was really already 10 years work to present that, but they kind of get short-circuited by increasing knowledge of RAS, and it's very hard to keep up with all that and have presentations that integrate the latest markers, which often evolve maybe the last 5 months before you have to present at ASCO. So having said that, if we go back to the Fire 3, if we go back to the Crystal, if we go back to the Opus, I think it's clear that extended RAS analysis is the way forward. It's clear for two reasons. One, because the more you remove RAS mutant patients from treatment with anti-EGFR agents, the higher the benefit of the remaining patients. So those that are completely wild type have higher hazard ratios. It's just a therapy which has much more higher efficacy indices in that population. So for that reason it makes sense. And a second, not unimportant argument is that it seems that in RAS mutants, depending on which therapy you're giving, there may even be some harm of the combinations, specifically true for oxaliplatin. But that is a very important argument. If you are unsure that you may be creating harm, I think it's a good way to go is not to treat RAS mutant patients. So in Europe, this is completely adopted based, I think, on a lot of nice consecutive data. We have moved towards the RAS wild type and are leaving away the RAS mutants. CLGB was presented with an old version of RAS, which kind of potentially underestimates about 15% to 20% of the patients that they presented as RAS wild type potentially will be RAS mutants at further analysis. But I think it's completely understandable that you can't just reanalyze your trial in 5 months' time like that. So I hope we get it as soon as possible, but it's that part that I would consider as the more mature data of CLGB. So I think we got a glimpse of CLGB, but it's really hard to interpret or make any final conclusions now, as we know a sizable part of the population will still shift. So I would prefer to keep the perspective of this towards the end of the year and then look at what we know rather than attach too much importance to what we know now in June. Yeah?
What's the next step from now?
In the next year, we're going to see a lot of retrospective subgroup analysis of all these trials. But then, of course, the only way forward will be to run a prospective, again, randomized trials in what appears to be the best subgroup. That is the courage step we'll have to take, and I hope that trial will initiate in 2015. So yeah, there is a clear way forward, but there's some decisions to be made which are not always easy to make fast. Yeah.
Okay, thank you very much for this interview.